Hi, good morning, everybody. Everybody knows I like quick introductions, so this will be quick. We've been trying to get Dr. Branson here for about a year, and so it's been a labor of love. He's very easy to work with. You have the formal description of his accomplishments and his past position at the CDC Associate Director for Laboratory Diagnostics, and one of the reasons it was hard to get him here is because he was just updating for the first time in 25 years the U.S. HIV testing algorithm, laboratory algorithm. So one of the things we're really interested in is that he's retired from the CDC, so that lifts certain constraints, and so I'm really looking forward to his presentation. And in the car driving over, he said, is this a group that would welcome an unconventional presentation? Raise your hand if you welcome unconventional presentations. Great. And so he's going to be talking later at UCLA with the UCLA Center for AIDS Research today on that new testing algorithm, and the title of his talk, Unconventionally, is Where's My Western Blot? But his presentation today is HIV and hepatitis C is eradication within reach. So please welcome Dr. Bernie Branson.
Thanks very much. I really look forward to speaking with this group and talking about maybe where we can be going from here. The outline of my presentation today is to talk about a little bit about where we've been and then a little bit about where we are, and ultimately I think then where we hope we can be, or at least where I hope we can end up being. HIV was pretty much first identified back in 1981, and I always like to start out to say who was not yet born in 1981. Can you raise your hand? Yeah, that's depressing. For me, in terms of where it comes from, because, when we talk about AIDS-free generation, there are many people who have not had a life experience that did not include HIV and AIDS. When I first got started, this was about in '83 in Baltimore when they first came there. Reagan was president, the president who never mentioned the word AIDS, as you can see, but this is just sort of the almanac of where things were then compared to where things are now. But this is a little reflection of the way the public was viewing things back then. This is a patient of mine who had agreed to be photographed during the course of his illness, and this is what AIDS was all about in that era. The other one is that it was not the government that got started in the response. It was a variety of community organizations and people who were coming from there. This is the program from the first International AIDS Conference. It was held in Atlanta. At that time, there were more researchers at the conference than there were people with AIDS in the country. In the plenary presentations, there were a couple of famous people who were there. It was James Curran from the CDC, Robert Gallo from the NIH, Luc Montagnier from France. And my notes from that point in time, 1985, indicated, according to Jim Curran, that they guessed there were between 500 and 1 million people infected, which was a pretty good guess. But at that time, they thought that only 1% of people with HIV would go on to develop AIDS. Nobody had an idea that the attack rate was that high. And so we've moved along, and we've learned a lot of things since that point in time. And then, of course, the test came out. And the test, when it first came out, again, the assumption was that people who tested positive were not necessarily going to get sick. They didn't know whether it meant you still had the infection or not for that. And HIV tests have evolved over time, and the evolution, I think, follows a backwards and forwards kind of course for stuff. I want to talk about testing, obviously, since that's a bit of my field, and there are 4 generations of HIV tests, and I think the easiest parallel for me to make is sort of a comparison with 4 generations of telephones, of things over time. And the newest, obviously, is sort of the best. We don't use the old dial-up telephones anymore in very many kinds of circumstances. The first generation tests, which came out in 1985, were made of whole viral lysate, taking HIV and grinding it up and putting it in a test, and it only detected IgG antibody. For those of you who aren't familiar with the science of it, IgM is the first antibody that appears after you've been exposed. IgG happens maybe 6 weeks or so later after the body has sort of become familiar with it. And importantly, the EIA, which was the original test, was a first-generation test, but the Western blot and the IFA, the things we use for confirmation, are also first-generation tests that only detect IgG antibodies. The CDC came down with their recommendation at that point in time about what we should do with respect to HIV testing, and that was in 1989 when they talked about the interpretation and the use of the Western blot assay. And the recommendation at that time was that nobody should get a positive test result until they had a repeatedly reactive screening test and a confirmatory test like the Western blot that was also positive, and that people couldn't get a result until both of those things had been done. At that point in time, just to remind you, Bush was president, Dan Quayle was vice president. Things had changed in '89, and of course other things that were state of the art at that point in time. Compact introduced its 26-pound portable personal computer. Most telephones still had wires during that kind of era. And the first test came out in 1985, which was the Abbott EIA, and then the Viranostica EIA, which remained the most commonly used test in this country until 2007, and then these confirmatory tests in the early 1990s, the ones we've been still using to confirm. Actually, in 1992, Abbott came out with a third-generation test, but that was only used for blood screening, and withdrew their first-generation test from the market. And then it was around 94 that we started doing oral fluid testing. This was conventional specimens that would be sent to a laboratory. And then the P24 antigen test was developed for screening blood donors, and the home collection system was introduced in 1996 as we sort of moved along. In 96, of course, was also the first government shutdown at that time, was when mad cow disease struck Britain, the Taliban seized Kabul. Things have really changed sort of since that point in time. But second-generation tests began to get introduced into the United States, and the second-generation test still detected only IgG antibody. And I mention that because while there were a couple of laboratory tests that were second-generation tests, the rapid test that became introduced, starting with the change in the recommendation in 98 to allow people to get their preliminary results of a test before it was confirmed, said that providers should provide those preliminary results from rapid tests. There was less concern about false positives, perhaps, than the fact that many people were tested and never got their HIV test results. And I want to mention that because essentially the tests like OraQuick and Multispot, Unigold, Reveal, the Clearview tests, those are all second-generation tests. They only detect IgG antibodies. And as I'll show you in a minute, this is important with respect to window period-related things. This was a time, of course, that the next Bush was president and the United States invaded Iraq. Things were happening at the same time as HIV. But then third-generation tests became introduced, and they detected the earlier antibody, both IgM antibody and IgG antibody. The earlier tests began to get withdrawn as these newer tests sort of came along, and then other developments happened, including something called chemiluminescent assays. So at the current time, there are these tests on the market, the Biorad, the Unigold Recombigin, the Siemens, and the Orthovitros, all of which are third-generation tests, which detect IgM antibodies. These big platforms on the bottom are important in terms of hospital screening because they are what are called multi-platform analyzers, and so hospitals and other big clinics that have these systems, it'll run 30 different kinds of assays, HIV, HCV, hepatitis B, and other things. You just basically put a specimen in there and ask for an HIV test, and it'll give you a test result in less than an hour. So we can now get rapid results from tests that aren't point-of-care rapid tests, and these are very important for hospital-based kind of screening. And finally, the most recent development in the United States was the introduction of the fourth-generation test. These are the ones that detect P24 antigen as well as HIV antibody. There are currently 3 of them available and FDA approved. 2 of them are laboratory tests, the Abbott and the Biorad. But there's also a rapid fourth-generation test, and this one basically has one place where it detects antibody and a different place where it detects antigen, and a different place where there's a control stripe. And this test can be done with whole blood or serum or plasma, and the company has applied for CLIA waivers, so it could potentially be used in a lot of non-clinical testing sites. And the difference really is going to end up being substantial with respect to that. The thing I'd sort of like to point out, though, is that as these other newer tests were improved, the other ones were withdrawn from the market, but our circumstance that we had until June of this year, basically, is that we were screening with third and fourth generation laboratory tests, or in community settings with second generation rapid tests, but we were still doing confirmation with these first generation confirmatory tests, like the Western blot and the EIA. I don't know if any of you see something wrong with this picture, but it certainly did not make a lot of sense to us in terms of what we were doing and what we were telling people about being infected. So the limitations of that old algorithm is that, number one, the antibody tests basically don't detect infection in about 10% of infected people who are at the highest risk of transmission. Those are the ones who have RNA but have not yet developed antibody. The Western blot is less sensitive than the other tests that we were using to screen people with it, and the Western blot also misclassified people who had HIV-2 infection. And I think that was not very well recognized, that folks who had HIV-2 would come out as positive for Western blot for HIV-1. And the problem with that is that the HIV-1 medications, like the protease inhibitors and some of the NNRTIs, don't work. against HIV-2. And so these people didn't get diagnosed until they got sick, despite the fact that they were taking treatment. So CDC did an analysis of all the tests that were available and FDA approved on the market. These are the uninterpretable results on seroconversion panels of individuals, about 27 specimens. In order to make sense of this whole thing, we basically drew a line across and said, when does each of these tests detect 50% of the specimens from seroconverters, and then compare them to see sort of how we were doing. We didn't know when these people got infected, but we did know when their Western blot turned positive, and so we compared all the tests to when they detected half of these specimens compared to when the Western blot detected half of the specimens. The Virinostica test, the one I told you that was most frequent, picked up infection about 2 days after the Western blot. And the reason this is important is that the package inserts of all the tests that we're using right now use this as the comparison. So when they say they're 100% sensitive, they're 100% sensitive compared to this relatively antiquated test. The rapid tests that have been used by a lot of community organizations, these are the CLIA-waived rapid tests, the second generation ones, pick up infection between 1 and 5 days before the Western blot. There's a couple of laboratory-based ones and one that was recently CLIA-waived, the INSTI test, that is about a week before the Western blot. The laboratory third generation tests, the ones that pick up IgM antibodies, pick up infection about 2 weeks before the Western blot turns positive. The fourth generation test about 3 weeks before the Western blot turns positive, and then RNA first shows up at around 26 days before the Western blot turns positive. So when people ask you what the window period is, obviously it depends on what test you're using very much. And the difficulty, of course, is that this period of acute infection in the very beginning is the time that we have most concern about, that I'm going to talk about a little bit more. That determined combo fourth generation test, as you see here, is a little bit better than the laboratory third generation tests, not quite as good as the laboratory fourth generation tests, but it's not only the test. And I think that one thing that is very important for people to recognize is that the oral fluid test has a window period that is 6 weeks longer than any of the other tests that we're using. So if we're trying to find people early in infection, testing oral fluid is not going to be the way to do it. The 42-day interval here is for the conventional test, the one that you send to the laboratory, but we have somewhat similar evidence, in particular with people on PrEP, that those who are following monitoring with oral fluid have significant delays if they get infected compared to testing blood in those situations. The question, of course, is why does this matter? And Joanne Steckler did this study at the University of Washington among MSM who were frequently tested, where they did RNA testing after antibody testing and found 192 were infected with HIV. Of those, 12% were detected only by RNA. And of the specimens available, 16 that were available for fourth gen testing, the fourth gen picked up 15 out of those 16 people who were otherwise detectable only by RNA. But the serum antibody immunoassay only picked up 88% of the people who were infected at the time they sought testing, and the oral fluid test only 80%. And so if we had relied either on a second generation antibody test or on the oral fluid test, we would miss 20% of the people who were infected at the time they sought testing and tell them they were negative, which I think is a pretty big problem. HIV-2 infection is uncommon in the United States, but it doesn't respond, as I mentioned, to some of the first-line therapies. It is not detected by viral load tests. It's misclassified by the Western blot, and it very often gets diagnosed only after people deteriorate immunologically and they get investigated further to look for HIV-2. So in June of this year, we came out at CDC with the updated recommendations for HIV diagnosis, and this basically starts with a fourth-generation antigen-antibody combination immunoassay. And if that's positive, you then go on to test people for antibody. And the test that we're recommending for antibody is one that tells the difference between HIV-1 and HIV-2 antibody. It's an HIV-1-2 differentiation assay. And the important feature is that if you're positive on that first test and you're negative on the second test, you then go on and test people for RNA in order to see whether they have infection, the early infection, before antibodies develop. In some cases, there's cross-reactivity, and it shows up for both HIV-1 and HIV-2, and it takes a little more investigation. There are a couple of indeterminate results, but very many fewer indeterminate results than the Western blot. But this is going to give us the opportunity to identify acute HIV infection. And I wanted to just mention in terms of HIV is that testing algorithm is almost exactly the same. You test people for antibody with HIV here, for HCV, I'm sorry, and then if that is reactive, you go on and test people for RNA to see whether they have active disease. So the strategy now for HIV testing and HCV testing is very similar from a laboratory perspective. The issue with using nucleic acid tests for diagnosis is an important one, but the regulatory structure here, and I'm glad I'm not at CDC anymore, is really stupid. Okay? Fourth generation tests were available in Europe 10 years before they got introduced in the United States. There is currently one nucleic acid test that is approved by the FDA for HIV diagnosis. It's the Aptima qualitative nucleic acid test. That test is not very widely available. Quest Laboratories is a pretty big one in the country. They do this test twice a week in 2 laboratories in the country. Quantitative viral load test, which clinicians use all the time, Quest runs 2 shifts a day in every laboratory in the country, but a laboratory can't use those to identify RNA, even though the clinician is going to want that result afterwards. And so it's part of our circumstance that creates this very weird thing where U.S. testing is behind the whole rest of the world. In terms of looking at this whole pattern now and putting it together with HIV infection and the laboratory markers, infection happens over there at point 0, as you see on the left-hand side. The first thing to show up is HIV RNA in plasma, which appears about 10 days or so after infection, and then P24 antigen about 15 days after infection, and then HIV antibody, first IgM antibody and then IgG antibody. The first generation tests basically pick up infection out here at sometime around 50 or 55 days after infection. But as opposed to window period, which is the interval between infection and the time the test picks it up, the thing I'm concerned about is acute infection, which is the time that RNA appears and the person is infectious before the test picks it up. And so with the first generation test, as you see here, they're infectious for about 6 weeks before the test turns positive. The second generation tests, including the rapid tests, are a little better. They pick up infection at about 30 days or 35 days after a person becomes infectious. Third generation tests are a lot better. It's only about 15-day interval. And the fourth generation tests, we're only talking about 4 or 5 days between the time a person becomes infectious and the time infection is picked up by those tests. And that is, I think, what we really need to focus on is what we're testing, especially in the era of PrEP. One thing we have recognized is that acute HIV infection is hugely important. This is a graph basically of HIV RNA copies in semen during the different stages of infection. And what you see here is that during the first acute infection period, the first 6 weeks or so of infection, you have basically 5 log copies, around 5 million copies of RNA present in semen. And in that long asymptomatic phase, the chances of transmission are much, much lower because there's just not that much virus circulating once the body gets under control. And this is without treatment. This is not viral suppression. These are just levels. The other thing I think people don't realize is that the virus that gets transmitted during the acute phase is in fact the Andromeda strain. There's a bunch of quasi-species, as I think you know, that a person develops, but the one that manages to get across the mucosal barriers in the body and establish infection is per virus somewhere between 75 and 750 times as infectious as the virus that's present during the long asymptomatic phase. So acute infection is very, very important. In addition, looking at studies of transmission, these are the particular studies that happened from the evaluation in Uganda. People during the acute phase, the short acute phase, are 30 times as infectious as people during the long asymptomatic phase when they're antibody positive. And so there's really a sort of a triple whammy. Looking at emergency department screening, this is from Phoenix. Phoenix is not exactly considered an epicenter of HIV in the United States, but they were screening in their ED with the 4th generation test and following the new algorithm. And so what you see here is in their screening of about 13,000 patients, they picked up 37 HIV infections, but 1/3 of them, 12 infections out of those 37, were acute antibody-negative infections. And the question is, why would that be? Well, when people get acutely infected, they feel sick. And when you feel sick, what do? You go to the ER. And so that's where they were picking up the infections. And we look at the viral load in these people, and the people who had acute infections had a viral load of 3.6 million. And the people with newly diagnosed antibody-positive infection had a median viral load of 25,000. So you can see the really significant difference in transmission potential that was picked up here just in a regular routine screening program in an emergency department. The other thing about acute infection is the people with acute infection are sexually very busy. This is an evaluation from North Carolina in that people with acute infection named 2.5 times as many sex partners, and of those sex partners, twice as many of them were HIV infected compared to the new diagnoses of people with established HIV infection. So we have a more infectious virus, very high levels of virus, and lots of sex partners during this acute infection phase. A variety of studies have looked at basically how much of all HIV transmission is attributable to acute infection, and the answer is probably half. Half of all new HIV transmissions are attributable to this really short acute infection phase that we've been missing with our testing up until now. In terms of the antibody test in the CDC algorithm, the one that is currently FDA approved is actually a rapid test, a multi-spot rapid test. It takes about 15 minutes. It's moderately complex, can be done in most different kinds of laboratories, and it tells whether antibody is present, and it tells the difference between HIV-1 and HIV-2. The major change, as I mentioned, with the new algorithm, though, basically is that if you're positive on any of these antibody tests, you don't stop with an antibody confirmation test. You basically go on and do a nucleic acid test in order to find these acute infections, which I think is crucial in terms of controlling the epidemic. You mentioned that sort of the title later on is Where's My Western Blot? Clinicians do not know what to do yet with this new recommendation. It's only been out for a couple of months. And people are used to thinking of the Western blot as being the gold standard, the be-all, the end-all for things, and we need to sort of educate them. In terms of the Western blot, it has really stood us in good stead. Many people are having trouble letting go of it. We decided to set up a support group in order to help out those folks who basically can't move on in terms of what the new sort of recommendations are. I wanted to mention, though, that now this was approved by the FDA October 24th, the Genius HIV-1/2 supplemental assay. This is for the second test in that algorithm. And basically, it's a cartridge that operates on what's called the dual path platform. Dual path platforms means you put the specimen on and it flows up in one direction, and then you put in the marker from a different place and it flows across in the other direction. This particular test, when you look at it, has basically bands for HIV-1, P31 and 160 and 24 and 41. It's also got bands for HIV-2. And it has a reader, which is, I think, really important for these tests that show up with little stripes on things. The reader, you put the cartridge in. There's no visual interpretation. It gives you a software-based interpretation that tells you whether it's HIV-1 or HIV-2 or negative. And the advantage of this test is that it can be done with whole blood or serum or plasma and takes 15 minutes. So that for people who are doing testing and we've been trying to figure out what to do with the preliminary positive result, we've got now something that will at least tell us who's antibody positive. And you see here, this is a positive on the right with all those stripes. The control is this one here on the left-hand side. But it's a 15-minute test, and again, the company is seeking CLIA waiver for this test, so it can be used in a variety of settings. We evaluated it at CDC, and I just wanted to give you an example of this is basically what the size is. You can't see it very well, but this is a mouse right here. So it's a pretty tiny little machine, very easy to set up. It's transportable. It connects with laboratory information systems through the computer. I've been trying to talk with the company to see if they'll transmit those results directly to surveillance so that we don't have this issue of, laboratory reporting. The other thing that's very interesting about this test is that they've developed an algorithm looking at the bands and how intense they are and the order in which they appear, and it looks like it does a pretty good job with this algorithm of telling whether someone has been infected in the last 6 months. So I don't know how many of you are familiar with what we do with syphilis, where we look at doing partner notifications for primary and secondary syphilis because it's the most infectious time period. We now have the ability with acute infection and with this test that will identify recent infection to focus our HIV partner notification efforts the same way on people who are most recently infected and most likely have been most infectious. So now to talk about sort of where we are. Currently with HIV in the country, there's about 1.1 million people who are infected. About 180,000, or between 16 and 18%, are unaware that they're infected. We really identified most people who have HIV, and there are about 47,000 new infections that occur annually in the country. I want to compare that now with HCV disease. In HCV, we're looking at somewhere around 3.2 million people in the United States who are infected, and 16,000 deaths a year occur as a result of HIV. And the best estimate basically is that about half of those people don't know that they're infected. We've been focusing, and this is the commission focus, on HIV, but relatively speaking, HCV is a big issue. And I am advocating that we use our HIV infrastructure to also address HCV because it has very, very many similarities. In terms of co-infection, the prevalence of co-infection varies by region, but it's estimated that about 25% of people with HIV are co-infected with HCV. It hastens the process, HIV does, of HCV liver disease, and liver disease is the second leading cause of death in people with HIV. These things go together. It's something that we need to sort of address. In terms of mortality, I think it's really, really interesting that in 2006, mortality attributed to HCV surpassed mortality attributed to HIV. More people die from HCV now each year in the country than die from HIV, and it's increasing. Because of the nature of what happens with HIV. This is the picture of HIV prevalence and incidence, so that you see in the red line, basically, because of all the advances we have in therapy, people are living longer, and we are having a larger number of people with HIV who are continuing to survive, thankfully, to old age. Incidence has stayed about the same lately, in the range of 50,000 cases a year. That's something we need to focus on bringing down. Looking at HCV is a very different picture. This is prevalence by age of people with HCV. And what you see is that people born between 45 and 65, that's where the bulk of HCV infection is. And the reason for that is HCV transmission was iatrogenic. We weren't testing the blood supply for HCV. It used to be called non-A, non-B hepatitis. You know, I'm old, and so I remember when doctors made house calls, and they would come to my house, and the doctor would want to give me an injection, and he would throw his glass syringe and his little needle in a pot of water on the stove in my mother's kitchen before he gave me a shot. That was not enough to deactivate HCV. And so since I was born between 45 and 65, I'm in this group here where the high prevalence of HCV is. It's really sort of a change in a very different epidemiology than HIV. So in terms of terminology, I'm going to talk about a couple of things with respect to testing. One is, of course, targeted testing, which is performing an HIV test or an HCV test on subpopulations of persons at higher risk. It's been our orientation for a long time with HIV testing. And then there's this concept of screening, which is performing a test on all people in a defined population. And we need both of these approaches in order to get both HIV under control and HCV under control. In terms of routine screening, which we recommended starting in 2006 for HIV, the criterion that you use to justify routine screening is, number one, it's a serious health disorder that can be detected before symptoms develop. Treatment is more beneficial when it's begun before symptoms develop. There has to be a reliable, inexpensive screening test. The cost of screening has to be reasonable in relation to the anticipated benefits. And critically, treatment has to be accessible if we're going to end up doing a screening. You don't screen for something that you can't do anything about. So the crucial issue here in both HIV and HCV from where we're at is that treatment is more beneficial when begun before symptoms develop. You don't wait till people get sick with HIV. You don't wait until people get cirrhosis with HCV, because treatment makes a bigger difference much earlier on. In terms of HCV, the risk-based strategies, just like HIV, have had very limited effectiveness. Previously, CDC recommended that you screen injection drug users, people who had a transfusion before 1992 when they started testing the blood supply. Many clinicians are not aware of these HCV screening guidelines. Many clinicians may be reluctant to talk with people about HCV risks, just like they are with HIV risks. And many people who have HIV don't know that they had some kind of risk exposure, so they wouldn't get tested if we didn't do screening. So in 2006, as I mentioned, CDC recommended screening people routinely for HIV in all healthcare settings. And in 2012, CDC recommended testing everybody born between 1945 and 1965 for HCV because of what their risk is. So we're talking about doing routine screening for both of these viruses in slightly different populations, but in the healthcare setting, because that's where people go, and that's where we're going to end up finding them. The Preventive Services Task Force finally in 2013 gave a grade A recommendation to screening all pregnant women and all persons at increased risk, and for screening people born between people who are 15 to 65 years of age for HIV. In 2013, they gave a grade B recommendation for screening people for HCV, and including people born between 45 and 65. I think all of you are aware how important this is, because under the Affordable Care Act, anything with a grade A or grade B recommendation is covered or should be covered by health insurance with no copay for people. Now that these both have these recommendations from the task force, we can screen for these and have it paid for by insurance. I just want to make a parallel because everybody's used to screening for cervical cancer, right? Doing, pap smears, that kind of thing. The doctor does it once a year for women. And we look at basically the annual new cases of cervical cancer that we're trying to avert are about 11,000 with 4,000 deaths compared to HIV when there's 50,000 cases and 15,000 deaths. For me, it's really tough in talking to clinicians because they do pap smears without giving it a second thought, but they say, why should I screen for HIV? Well, I think this is why. We can prevent 4 times as much disease and a lot of mortality, and it's a very similar situation with HCV. Screening works. The success that we have had, this is the example of what's happened essentially with vertical transmission, mother-to-child transmission. We started basically screening for people back here in around 1996, and the number of annual cases went from about 1,000 down to 20 as a result of doing this screening and kinds of intervention. The screening the blood supply has virtually eliminated HIV as a result of transfusion. We now have to work on injection and sexual transmission from the same kind of perspective. In terms of HCV, I wanted to talk about what the future morbidity and mortality is, because while HIV is going down, HCV is going up. Looking at the health outcomes, at least modeled on this, basically it's anticipated that somewhere around 900,000 people will die from HCV-related complications if we don't treat them. In terms of the graph of things, here we are basically at around 2014 with around 10,000 deaths attributable to HCV per year. If we look at around 2032, we're talking about 35,000 deaths per year if we don't do something about it. This is the reason why I won't talk about HIV these days without talking about HCV, because we have another whole epidemic on our hands. I don't want to call it an epidemic because it's been around for a while, but we have a huge health condition we can do something about. So the medical rationale for both of these are the same. Treatment is effective. Treatment is recommended for everybody with HIV infection since March of 2012. Treatment cures HCV. This is incredible, the advances that we've made. There's now basically 12-week therapy that will cure people with HCV infection. This is the picture with HIV in terms of survival here, where in the pink is the deaths that happen per 100-person years, and on the blue are the patients who are on highly active antiretroviral therapy. And those curves crossed in 96 when triple therapy became available, and they continue in the same sort of pattern and direction. Looking at the per-person survival gains with HIV compared to things like chemotherapy or coronary artery disease treatment and stuff like that, we're looking at this phenomenal advantage that we give to people by treating their HIV in terms of life expectancy. In terms of HCV infection, cure is called sustained virologic response, which means you don't have any virus around anymore. And sustained virologic response from currently available therapy is associated with a 70% reduction in liver cancer and a 50% reduction in all-cause mortality in people who get treated and get to sustained virologic response. In terms of HCV therapy, this is a very new thing. Since 96, we've been pretty comfortable with HIV therapy. The stuff here with all oral regimens, these short course regimens, has only become available in 2014, where we can cure more than 90% of people with HCV. That's very different than HIV. It's something that's recent. It's word that has not yet really quite gotten out. The next big issue for this is the potential effect on transmission. There's behavior changes. People who find out they're infected with HIV basically have a 68% reduction in their unprotected anal or vaginal intercourse with HIV uninfected people just from finding out they have HIV infection. They don't want to infect somebody else. But more importantly, we've learned that antiretroviral therapy can stop transmission. This is a randomized controlled trial that came out, as you see here, in the New England Journal. It was in Science Magazine, the breakthrough of the year in 2011. Science Magazine only gives one award for breakthrough of the year, and this demonstration that treatment prevents HIV transmission was considered hugely important. This was the HBTN 052 study where they recruited discordant couples and followed them, those who were on therapy and those who got delayed therapy. There were 39 total transmissions here. 28 of them were linked transmissions, which means it was the same genotype in the person who had the infection and the person who acquired the infection. And basically there was a 96% reduction in people who received therapy. The thing I do want to focus on, though, are these 11 unlinked transmission, which is that in these discordant partnerships, some of the negative people got infected by somebody who wasn't their partner. And the reason I think we're talking about not only treatment, we're talking about PrEP, is that people who have exposures to HIV don't necessarily get it from their primary partner, and we have to look at ways to both treat the person who's infected to reduce their infectiousness and treat the person who's uninfected to reduce their susceptibility. So viral suppression as prevention. I heard you sort of talking about it. I'm the co-chair of HPTN 065, which is the test linked to care plus treat protocol, which is the one trying to see whether we can actually put this into practice to test people, link them to care, get them to stay in care, make sure they get on antiretroviral therapy, and make sure they adhere to the therapy for viral suppression. Everybody, I think, has seen these cascades, sort of what happens, where maybe 80% of people are aware that they're HIV infected, 62% of them get linked to care. Unfortunately, only 40% stay in care. This is the big fall-off here between first getting identified and staying in care, and ultimately about 28% is estimated are virally suppressed in this country. That's not good enough to bring the infection under control. That's not good enough for eradication. HCV is much worse. Basically, only 50% of people with HCV know they have HCV. 38% of them end up in care. 31% of them have an RNA test. 18% of them get treated, and only 14% of them have actually got sustained virologic response. Remember, this is not lifelong therapy. This is 12 weeks and over that you're cured. We have a lot more progress that we can make with HCV. The other issue for me, this is the cover of The Economist 3 weeks ago about the gay divide. What we are talking about with respect to a lot of the problems with HIV is very, very limited to specific populations. This is the pattern of incidence of HIV in the country, and what you see is that among MSM, incidence is going up. Among heterosexuals, among injection drug users, incidence is going down. We have a divide. We have two different patterns. We have people we need to focus on. In terms of estimated new infections, I'm sorry that this is such a lousy slide to see, but basically in this light blue are people aged 13 to 24. These are young people, and the largest number of new infections is happening among black people, black men aged 13 to 24. Looking at the incidence in young MSM, 13 to 24 in a different way, what you see is basically every year, 2007, 8, 2009, 2010, the incidence is going up in people aged 13 to 24. These are people who are getting HIV before they even know what they have to worry about. I'm talking about we need to start young if we're going to be focusing on doing this kind of prevention. Hepatitis C is a different picture. Hepatitis C was actually really bad, as I mentioned, before we started screening the blood supply. When we started doing surrogate testing of blood donors, we had a big decline in transfusion recipients. And then we came up with the anti-HCV tests that were widely applied to both the blood supply and to other circumstances, and we saw big declines in HCV infection among persons who inject drugs. So we're not talking about new cases of HCV here like we are with HIV. We're talking about old cases that we sort of have to deal with. Among MSM, looking for acute HIV infections, these are from several different studies. Essentially, almost all the acute infection that we detect in MSM. So that in the study I showed you in Seattle, 20% of all the HIV infections that were present at the time people saw testing were acute infections. This is in Los Angeles, where CDC did its acute HIV infection study. There were basically 5 STD clinics and LAGLC that participated, and 74% of all the acute infection cases came from that one clinic for men who have sex with men. New York City STD clinics is the same thing. 10% of all HIV infections detected were acute infections. 94% of them were among MSM. So we have to clearly focus our efforts in that direction. And this is, the way we need to go in terms of preventing acute infection. We do need to keep people on therapy who have HIV to have them virally suppressed, but we have this new tool to make people less susceptible to HIV, and I think this is something we are all grappling with in order to how to use it. What's happening with PrEP? Looking at PrEP and its adherence, there was no question that you have to take it in order for it to work. These are the overall results of the different studies. What you see here is in the overall study, basically 49 to 75% of people were uninfected. If you look at the people who had drug present, when they came in. The rates are 90 to 92% of people who are prevented. The issue here with PrEP is that you have to take it. Looking at people who had the activated form of the drug according to their blood tests at the time across different visits, what we see is that people who essentially always had drug measurable, it was 94% effective in those folks. People who had sometimes drug effectable, it was about 60% effective. People who had never had drug detectable, they got more HIV than the people who weren't on it. So, there's no question here that if you want it to work, you have to take it. Looking at the clinical practice guideline from CDC, which was issued just in 2014, in March of this year, they tell you what you have to do is review. This guideline reviews all this evidence on efficacy and safety. It tells you about identifying patients who have indications for PrEP and contraindications for PrEP. The guideline talks about prescribing, laboratory testing, follow-up care, supporting adherence, related kinds of stuff. And the indications of PrEP are to do a brief sexual history, similar to what we've been doing. Do you have sex with men, women, or both? Do you use condoms? Do you do it consistently? How many sex partners do you have? Do you know what their status is? Have you had STIs? Do you use drugs? When's your most recent kind of exposure? Contraindications, obviously, is people who are HIV infected. You don't give them 2-drug therapy when you need 3 drugs for that. If they have recent signs or symptoms of an acute viral illness, they might have acute HIV. You don't want to start them on a 2-drug combination. And, of course, people who have pre-existing renal or bone disease. Testing for PrEP is an HIV test, a creatinine test for the kidney function, hepatitis B test if people are unvaccinated, a pregnancy test, and tests for sexually transmitted infections. Follow-up visits for PrEP every 3 months, an HIV test to make sure that people don't get infected despite having been on PrEP. A creatinine test at the first 3-month interval and then twice a year. Pregnancy tests, STI tests, and then assessing medication adherence and HIV risk and protective behaviors so that we see exactly what people are doing. This is evidence from community settings about PrEP works if you take it. These were in 3 different cities, 4 cities, Miami, D.C., and San Francisco, overall. And what we see is that in different places, people had different levels of motivation. The lowest in Miami, only 50% of people had blood levels at the time they came in, even though they were supposed to be on PrEP, compared to San Francisco, where 92% of people had PrEP in their bloodstream when it came in. Adherence matters. Daily doses of PrEP will provide high levels of protection. There is some forgiveness if people miss doses occasionally, but there's clearly no evidence that PrEP works if you take it sporadically or intermittently. This is not a morning after drug. It's probably a morning before drug. It has to be there at least 4 days in order to offer you some kind of protection. But this is the potential impact of PrEP for MSM in New York City, looking at HIV prevalence over time. This is if you don't give any PrEP, prevalence continues to slowly flatten out. If you only have 44% efficacy, like in the trials where people weren't taking it, prevalence still comes down dramatically. If you have 73% efficacy, prevalence comes down even more dramatically, so that even if PrEP isn't perfect, it's going to make a huge difference in eradicating the epidemic that's here. Where we've been for a long period of time is basically the ABCs, right? Remember Smokey's ABCs are preventing forest fires? Abstinence, be faithful, use condoms. That's been our big, way to prevent forest fires. I maintain that basically PrEP is now the way to prevent forest fires. We have to definitely treat people. I feel increasingly strongly about this, and I have to tell you that I'm a convert, because for a long time I said, look, we need to focus on getting people with HIV on therapy first before we worry about putting people without HIV on therapy. And I don't think it's an either-or question. The answer is clearly both. That's the direction that we need to go in. One map, I guess, that I want to show in terms of being an old person. I had polio in the last epidemic before the vaccine in 1952 in the country. And this basically is the picture of polio eradication in the world over the same interval we just talked about for HIV, from 1988 to 2014. And what we see is that we virtually eradicated polio from certainly this hemisphere and from most of the world in the same time interval where HIV took its place as being the new scourge or the new plague that came around. And so what I encourage people to do is tell it like it is. Number one, the epidemic is over in the United States. We keep talking about the epidemic. It is endemic in the United States. Okay, epidemic when the number of cases were doubling every 6 months, like happened in the 80s. It is now hyper-endemic in certain populations, as I pointed out, like MSM, but we need to use tools to deal with an endemic condition that are different than an epidemic condition. Okay, Ebola is an epidemic, let's face it, right? That we use specific tools to deal with an epidemic, so that no matter what the communications people say, we don't have an HIV epidemic. We have an HIV condition that we now have to use our tools to deal with endemic conditions. The second thing is this old debate about prevention versus care and treatment. I mean, I think this has been going on. How much should we concentrate on each one of these areas? The goal for prevention is 0 new transmissions. The goal for treatment is 0 new cases of progression to AIDS. People who have HIV, we can keep them from getting the complications. People who don't have HIV, we can keep them from getting infected. We are looking for this so-called AIDS-free generation, and as I showed you, we better start young. We have to use the tools we have in terms of PrEP. We have to use techniques that have worked before. You know, when syphilis outbreaks happened, they used to do a blitz, where you cover a neighborhood, basically. And when we start seeing acute HIV infection, we need to do the same thing. But the real issue is we have to start young if we want an AIDS-free generation. You know, if you already lost the battle, by the time somebody is 24, you're going to be in sort of big trouble. So that's pretty much all I have to talk about today. And I'll be happy to answer some questions and have some discussion. Thanks very much.